Welcome to chapter 46. This is part 2. And we're going to be covering hips and knees. So total hip, total knee. We're going to start with total hip. So a total hip replacement. What are we talking about? If you go back and look at the previous video, I discussed what actually happens when we talk about a broken hip or a fractured hip. It's really not the hip itself. It's usually the head of the femur that's broken. And most often the patient will require that ORIF, open reduction internal fixation. And so most of the questions that you're going to be asked are going to be, what is your job as the nurse in caring for this patient? What kind of patient education do you have to provide so that the patient takes good care of themselves? So first we'll talk about pre-op. Before they go in for surgery, remember, it's the surgeon's job to explain the procedure. Understand what's going to happen while they're in the operating room and what they can expect afterwards. So when you witness an informed consent, what you're really doing is you're witnessing the patient's signature. You're not witnessing anything more than the fact that the patient's awake, alert, and oriented, and they're not under duress. In other words, nobody's got a gun to their head and saying, sign this. They're doing it of their own free will. So you want to make sure that up until the very minute that they're getting rolled into that operating room, if they have questions, then you have to say, stop, let me get the surgeon for you, and let him or her do their job and then re-explain. There's a typical amount of blood loss that occurs with any surgical procedure. Sometimes for some people, it's more than we expect. You don't really know what's going to happen in the operating room until you actually cut a patient open and get inside and see, because sometimes we find things that we didn't necessarily expect. And sometimes blood loss can be more than what we anticipate, which would indicate the patient would be in need of a blood transfusion. Well, most often what we can do with these kinds of planned surgical procedures, we can offer the patient this option called an autologous blood donation. Auto is right there in the word, right? I'm looking at slide 2. Autologous blood donation. So if I know that I'm going into the OR for surgery and there's even a slight bit of concern about blood loss and I'm not real cool with having a blood transfusion if it's somebody else's blood, even though I want you to know it's safe, right? It's checked for HIV and hepatitis and all those things. But anyway, I can donate my own blood in advance. So this way, it's waiting for me in the event that during the procedure or after the procedure, there's excessive blood loss and I need blood, I can get my own blood back. So make sure you know that. That is an autologous blood donation. Okay, let's move on to post-op care. So we want to prevent complications and promote healing, right? So the big thing we're worried about is a dislocation of the hip or non-healing of that surgical site. So the number one thing we want to do is we want to prevent adduction. So remember back in term 1, when you had body structure and function in the very beginning, we talked about the body planes. So and positioning. And one of the things we talked about is abduction and adduction. The easy way to remember it is when you adduct, you add, you bring together. When you abduct, you move apart. So we want to prevent adduction, because if the patient brings their legs together, there's a very good possibility that they're going to dislocate that hip. And then they're in for a real bad surprise. They're going to wind up going back to the OR. And nobody wants to go into surgery more than they have to. The other thing we're worried about, of course, is the incisional site, to make sure that it's free from infection, that it's healing appropriately. We want to make sure that we don't have any additional skin breakdown in areas other than the incisional site. So in other words, if the patient, they're going to be immobile for a small, short period of time, we want to make sure that we're checking their skin integrity to make sure that it's not becoming compromised with pressure ulcers. And then pain. It's going to hurt. And you want to make sure that you are providing adequate pain relief. If the patient is in pain, and remember back when we talked about pain in the pain video, pain delays the healing process. It elevates vital signs like respiratory rate and heart rate and blood pressure, And all those things will impede the healing process or slow it down. The slower the healing process, the greater the risk for infection. And that makes sense, right? The longer there's an open wound, the longer it takes the wound to heal, the higher the risk of infection is. Okay, so make sure that you remember that. When I look at the next couple slides, slides 4 and 5, when you look at slide 4, you can see that the patient's in bed and they have between their legs an abduction pillow. You can use a regular pillow or a couple regular pillows, but most facilities do have these pillows. They're kind of shaped like a triangle. They go between the patient's legs while they're in the bed and prevent them from adducting. They keep their legs abducted, so keep the hip where it needs to be. And then slide 5, you can see when we're talking about posture and how the flexion of the hip can affect the healing process. If you look at the first little picture there, the man is sitting in a very nice, good posture, upright position. When you look at the second picture, do you see that bend? He's kind of bending over. Never, 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 never should a post-op hip patient bend from the waist. That is considered a 90-degree bend. And what it can do is when they bend from the waist, boop, it'll pop that hip right out, dislocation of the hip. Again, we don't want that. So the next slide is going to tell you about very specific things that need to be done. And remember, specific, you can't just say things like prevent infection. Well, how? How? Always read the care plans that are in your textbook. I'm not telling you to read the whole chapter necessarily, but the care plans, the nursing process for care of a patient with an ORIF or a knee arthritis. Read the care plans. That's where the meat and potatoes of your information is going to be found. Okay, the next slide, I'm looking at slide number 6, talks to you about postoperative care. So we want to prevent complications. Not all of these things are done every time. Like, we don't always give a prophylactic antibiotic to prevent infection. That depends on the surgeon. But there are many surgeons who just, typically will prescribe an antibiotic IV postoperatively just in case, just to prevent infection. Coughing and deep breathing. I cannot stress this enough. Here's a little tip too. Smell the roses and blow out the candles, right? What does that mean? So you want to make sure that your patient is getting in nice deep breaths and filling up their lungs, and that they're also getting all that carbon dioxide out, right? So there are a couple different ways that we do this. One of the ways we do it is we teach coughing and deep breathing. So we instruct the patient, take a deep breath in and cough. Older people, weak, frail people sometimes don't have the strength to do that. So another approach that we can use is that smell the roses and blow out the candles. And what you're doing is you're teaching the patient to take a very, very deep breath, as deep as they can, in through their nose, smell the roses, right? And then when they exhale through pursed lips, they're going to blow out the candles. So, and then I coughed. That's what's supposed to happen. So when you blow out, when you exhale forcefully through pursed lips, and that's important to remember, pursed lip expiration. What you're doing is you're actually getting your lungs, you're squeezing them, and you're getting out all of that carbon dioxide, right? So the deep breath in is promoting filling up those lungs. Lungs are kind of like two balloons inside your chest. You need to fill them to their maximum capacity, and then you need to empty them as much as you can. And then there's a third thing that we do, and that is a little gadget called an incentive spirometer. I'm sure that in Foundations Lab with Miss Sandy, you've seen it. So it's a little gadget that the patient can hold. It's got a tube, corrugated tube with a mouthpiece. And the patient places it in their mouth, and when they take a deep breath in, they're going to watch. This is the incentive part. We're incentivizing them to use it. They watch this little, it's either a little ball or a little, plastic piece that's colored. We watch it rise as they breathe in. And it'll be up to a number, so it's calibrated. And the incentive part is that we're saying, come on, you got up to 700. Can you get that little ball up to 800 or 900 or 1,000? So we're giving them incentive, and we're giving them something tangible that they can hold and feel and look at that encourages them to get that deep breath in. And why are we doing all of that? Well, we don't want them to get a post-op pneumonia. Remember the word stasis, also the word static, right? If something is static, it doesn't move. So when we talk about stasis, a patient can have venous stasis, in other words, blood not moving, which is very bad because blood's got to always be moving. And then stasis can occur in the lungs, pulmonary stasis. So if you're just lying there and you're just breathing shallowly, you're not expanding and contracting your lungs the way they need to be. And what can happen is whatever secretions are there, and we all have secretions, they'll accumulate, and the patient can develop a postoperative pneumonia. And we don't want another problem to add to the list of problems, right? So with the incentive spirometer, remember, 10 times an hour. 10 times an hour. I used to tell my patients when I worked in the hospital, you're sitting there, you're watching television, every time a commercial comes on, use your little gadget. And that would amount to about 10 times an hour, pretty much. So we can either cough, deep breathe, we can smell the roses, blow out the candles, we can use an incentive spirometer. Those are some of the things that we can do. When we talk about bleeding, of course, you're going to be monitoring the incisional site, making sure that there's no excessive bleeding. We just cut the patient open, so it would be normal for you to observe a scant or small amount of blood, sanguineous drainage, or you might see a scant or small amount of serous drainage. Serous drainage is thin, clear to a very, very pale yellow, watery kind of drainage. It's lymphatic fluid and white blood cells and stuff. It's normal to see that. We might see serosanguinous, which is serous drainage tinged with a little bit of blood. That's okay too. And we're going to see a little erythema or redness at the incisional site. We just cut you open, right? So that would be normal. What we don't want to see is any excessive swelling or edema at the site, any increase in the erythema, or erythematous streaks, so red streaks coming from the incision. Those are screaming signs of infection, okay? And then the other thing are the neurovascular checks, because remember, we said the nervous system, vascular system, musculoskeletal system, everything works together. And so you're always going to be checking distal pulses, distal capillary refill, distal sensation. In other words, if I had my right hip done, you are going to start at my feet. You're going to assess my left foot, cap refill, warmth, is it warm, is it cool, color, is it normal for my ethnicity or does it look pale, and sensation. Can the patient feel me touching like the bottom of their foot, their toes? So that's your baseline, and then you assess the affected foot, the right one. That's where I had the surgery, right? So you're going to assess the right pedal pulse, capillary refill, color, temperature, sensation. Don't forget that, all right? And if there's anything out of the ordinary, maybe the pedal pulse is hard to palpate, then you're going to move up to the next pulse. And just so you are all aware, when it comes to peripheral pulses, dorsalis pedis, the pedal pulse, is at the top of the foot. Post-tibial is right behind the ankle. Popliteal is behind the knee. Femoral is at the groin or inguinal area. Those are peripheral pulses of the lower extremity. You must know them. Okay, so now we're going to move on, and then things to prevent other complications postoperatively. Ambulate, 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 out of bed, 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 up, 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 right? Get them out of bed as soon as you can. We never, ever, ever will leave someone lying in a bed postoperatively. Early ambulation is really the key to preventing these post-op complications, specifically DVT and postoperative pneumonia. We'll usually get them physical therapy, and we'll usually get an assistive device like a walker. Not usually crutches. I know that the PowerPoint says that. I probably should have deleted it, but older people have a very hard time with crutches. Walkers are just easier. And when a patient's using a walker, have you ever seen a patient use a walker and they're leaning over? They need to be in an upright position. When they're leaning forward using a walker, they're throwing off their center of gravity, and they're actually more likely to fall forward flat on their face. Okay? So these are all things that you need to know. Moving on. The next slide, slide 8, talks about thromboembolic prevention, okay? It's a mouthful, right? So thromboembolic prevention, thrombus or embolism, clots, right? We want to prevent them. We want to prevent DVTs. We can use different things like compression devices, also called SCDs or sequential compression devices. So these are, they kind of look like plastic boots with Velcro, and they wrap around the lower extremities from the ankle to the knee. They have a tube that comes from them to a pump, and what happens is when they're plugged in, the pump just blows up the boot around the leg, squeezes the leg, and then it releases the air. So squeeze, release. And we're doing that to the lower extremity with these sequential compression devices because that is mimicking what the muscles do when you're walking. They squeeze and release, and that's how blood gets back up through the veins. So that's important to know, sequential compression devices. Patients should be doing some leg exercises when they're not ambulating, like pumps, pedal pumps. In other words, like you're driving your car, pushing on the brake and pushing on the gas, push on the brake, push on the gas. And then most surgeons will have the patient on some kind of a prophylactic anticoagulant. The most common one is enoxaparin, Lovenox, and that's just to further prevent the blood clot risk. And then, you're going to be educating the patient on how they're supposed to be taking care of themselves. So how are they getting dressed? There's a thing called a grabber, right? Usually occupational therapy will provide them for the patient. It's this long kind of stick thing, and it's got a handle on it so that they'll never be inclined to bend over to pick something up. They can use their grabber. They should always have a raised toilet seat and raised seating. So in other words, they should never be sitting in something that's very low to the ground because they're more likely to pop that hip out, dislocated, right? And then rehab. Most patients we will either send to an inpatient rehabilitation center, or they even do home care where we can send a physical therapist to the patient's home to provide therapy at the patient's home. All right, that's enough for for hips. Let's talk about knees. So when we talk about a total knee replacement or knee arthroplasty, well, that means we're going in and we're replacing either the head of the tib-fib or the distal portion of the femur or part of the patella. So that's all that's in the knee. And etiology, it's usually because of osteoarthritis, age, wear and tear, right? Over the years, things start to wear out. And so what happens is eventually you got bone on bone happening in that knee joint, which is very painful and damaging to the knee. Knees don't dislocate, so we are not worried about dislocation with knees. Things that dislocate, ball and socket joints, so we're worried hips and shoulders, but not knees. And just the post-op care for a total knee is similar to a hip, except there's one thing that you need to know, the CPM machine, continuous passive motion machine. Slide 11, I have inserted a picture for you guys so you can kind of look at that and see what the machine looks like. That's why I posted the link for that video so you could watch that. And it's just a machine that's constantly providing passive motion, flexion, extension, flexion, extension, flexion, extension, because movement of the joint with the flexion and extension promotes synovial fluid production. Synovial fluid is that lubricating fluid that's inside the bursa of the joint that keeps it moist and lubricated, and that helps it heal. So that is very, very important. What do you need to know about the CPM machine? Number one, never, never, never store a CPM or anything else for that matter under a bed, on a windowsill, on the floor at all. In a facility. Facilities are filthy places. So no equipment should ever be placed on the floor, the windowsill, under the bed. Okay? Don't be tricked if you see a question like that. When the patient's utilizing the machine, they should always be at least in a semi-Fowler's position. If you have the patient in a high Fowler's position, every time there's flexion, and let me see if I can move the camera out and kind of show you what I mean. I'm going to try anyway. There we go. So if I'm in a high Fowler's position, sitting up real high, and my knee is doing this, basically you're forcing the patient to do abdominal crunches. I can do them, but can they? Painful, right? So you want to make sure that your patient is in semi-Fowler's, kind of like a reclining position, so that it's more comfortable. Nothing ever goes on the machine. You don't put a pillow on it or anything like that to cushion the leg. There is a lamb's wool liner that goes on, and nothing else. Nothing else. Never touch the adjustments, the settings for the flexion and extension. That's something that's between the therapist and the physician. They're the ones that know how to adjust those settings. That's not a nursing task. And the patient should be on it really 23 hours a day, minimally, right? Medicate them for pain if they're uncomfortable, because they need to be on that CPM machine as much as possible to promote the healing process. It is critically important. Can't stress that enough. Okay, and then last but not least, this is always a fun topic, amputation. So the word amputation means the removal of a body part. And it can be surgical, in other words, something that we've done that we needed to do, or it can be traumatic. So when I worked in the ER, I had a patient, he worked for the telephone company, and this is how long ago this was, in the 90s. And he was driving his truck with his arm hanging out the window. He was in an accident, and he lost his arm right there. Couldn't be reattached, sadly. But amputations can happen traumatically. They can happen because of car accidents or other accidents, right? For the most part, we're going to be talking about surgical amputations. Why would we have to remove someone's body part? Well, it's usually either above the knee, below the knee, or it can be upper extremities, but the most common ones are lower extremities, and it's usually because of ischemia, because of peripheral vascular disease, and uncontrolled diabetes is the number one cause. Did I say that? Let me say it again. Uncontrolled diabetes is the number one cause of amputation of lower extremities. And when we get to the endocrine system, you'll understand this a little bit more. But diabetes mellitus in and of itself is not the thing that's going to kill you. What's going to kill you, and it's going to kill you slowly, by the way, not quickly, which is terrible. It's uncontrolled diabetes. When patients have these spikes in blood sugars, right, because they're non-compliant, they don't follow dietary restrictions, etc. Every time the sugar in their blood is elevated, think about it like this. Would you put your baby to bed every night with a bottle of Pepsi? You would never do that, right? Because you know that all that sugar in the Pepsi is just going to eat away at their teeth, right? It's going to rot them. Same principle here. When the sugar in a patient's blood is elevated, that sugar in their blood, because blood is everywhere, is just gnawing away at the vasculature, blood vessels, and nerves, especially most distal. So we're talking about feet, lower extremities. Important to remember. And also people with uncontrolled diabetes are more prone to infections. They have delayed healing process. All those things are problematic. People with diabetes are immediately considered a higher risk candidate when it comes to surgical procedures. Okay. I'm going to make this part short and sweet. I'm not going to get into replantation. There are certain situations where we can reattach it if that's the case. keep that limb on ice if there's an accident and something gets chopped off, because we might be able to put it back like Humpty Dumpty. But what do you need to know? You need to know about nursing care postoperatively for the amputee. And if you look at slides 17 and 18, really I go into detail. So nursing care. For post-op care, you want to make sure that you are preventing hemorrhage. So you're checking the site, the incisional site, making sure that there's no excessive bleeding, making sure that you don't see purulent drainage, right? Pus, anything that's thick, green or yellow, has a foul odor to it, right? You want to make sure that you're managing the patient's pain, because they're going to have pain. And briefly, I will talk about phantom limb pain. This is the weirdest thing ever. And until you actually see it in a patient, it's hard to even get. When a patient loses a limb, very, very frequently and very commonly, they will still feel the limb as if it's there and it hurts. Yep, I know. Phantom limb pain and sensation. Sensation is they feel that the leg is still there, even if we've amputated it, and they feel pain in the leg, even after the amputation. So, you want to manage their pain. That's neurological pain, and there are medications like Lyrica, Neurontin, which is gabapentin. We'll get to those in Pharm too, so you don't need to know them right now. But you want to manage the pain as far as their surgical post-op pain. Morphine, right? Dilaudid, Demerol. So all those things talked about in Pharm. Okay. You want to make sure that after surgery, you're checking the patient's dressing. They're going to have usually a soft dressing. Sometimes they'll have a rigid dressing, but that's not common. And you're making sure that the dressing's intact. You're changing it according to facility protocol. Positioning. I highlighted this on slide 18 in yellow so you would know. The patient needs to be repositioned at least every 2 hours. And, this is important, they need to be placed in a prone position with every second or third rotation. So in other words, face down. Why? And it's very rarely that we'll tell you, put the patient in a prone position, face down. It's important post-amputation that the patient be positioned in a prone position every second or third position change to prevent hip flexion contractions, because the bottom part of that leg is no longer there. If they're lying supine all the time, there's going to be a tendency for the hip to contract, and once it's contracted, it can't go back. All right, so remember that. That's why it's yellow and it's underlined. Okay, make sure you know it. There's something called molding that we do to prepare the stump for a prosthetic device or, a fake leg. It's called a prosthesis. Actually, the word prosthesis means an artificial replacement of a body part. So in this case, we're talking about a limb, lower extremity. Molding is getting that stump, the bottom of the stump, to form and kind of get a little bit tougher so that the person can fit them for the prosthetic device. And I talk a little bit in the PowerPoint about having the patient push that limb, right, the affected limb, into a soft pillow and then a little bit harder and then into a harder surface gradually over time to get it molded. And there are molding devices that kind of look like compression stockings that will go over the stump to help get it in the right position that it needs to be in so the patient can be fitted for the prosthetic. There are a couple questions and answers on here, so make sure you go over those, and if you have any questions, you know where to get me. Holla! All right, until the next part, see